So good morning, good evening, good afternoon to everyone. As attendees start entering the Axiom Healthcare Strategies ESMO Town Hall, give a quick introduction. This is the final session of our 5-part series following ESMO. We've had a few great topics over the past few days, from NSCLC to the next wave in oncology. And today's focus is going to be on that of GU tumors and the key data that was presented at each of those. So we're welcome to have host Dr. Srivanas, Dr. McDermott, as well as Dr. Powell, and they'll walk you through a lot of the key updates and lessons learned from ESMO this past year. So to give everyone a quick introduction to how the next hour will flow, what you'll see is we're going to spend time on each tumor. So within the bladder session, we'll talk about some of the findings from Keynote 361, Danube Trophy, as well as some additional subgroup analyses of Javelin. For RCC, we'll gain some insights around Checkmate 9ER, Cosmic 021, as well as a new agent within HIF2 alpha. And within prostate, we'll close out speaking to Profound, as well as eye potential and Amgen's agent, the PSMA targeting BiTE component. So I will pass off the baton, as they say, to Dr. Powell, who's going to help guide us through bladder cancer.
Thank you, John, and thank you for inviting me to this this event with Sandy and David. If you have got questions, please reach out to us, and I think we're going to get those questions live, and we'll try and answer them in real time. We don't have many slides. I don't have many slides, and the purpose of this is really more of a discussion-based summary rather than necessarily death by PowerPoint. You're probably aware that urothelial cancer, bladder cancer, has moved on a great deal, or a huge amount of information has become available. Whether we've moved on or not is a discussion for a different day. But I hope by the end it'll be clearer whether or not these trials, these huge 1,000-patient frontline randomized phase 3 studies, Keynote 361, Danube, IMvigor130, all of which test standard chemotherapy, Gem-Cis or Gem-Carbo, against monotherapy, durvalumab, pembrolizumab, or atezolizumab in the biomarker-positive population. And all 3 of those studies have a third arm, and that third arm is either chemotherapy plus the immune checkpoint inhibitor combination, or, as you'll see in a minute, Durva, Tremi, PD-L1, CTLA-4. And that third arm has always been tested in an ITT population. So in summary, the trials are very similar: chemotherapy versus monotherapy immune checkpoint inhibitor in the biomarker-positive cohort, and then in the third arm, either chemotherapy combinations or CTLA-4 PD-L1 combinations in the ITT population. Overall survival, the endpoint for all of the trials have very similar entry criteria, all of them 1,000 patients or more. This is Keynote 361. Before we saw Keynote 361, we saw IMvigor130. IMvigor130 had an almost identical design. So it was chemotherapy versus chemotherapy plus atezolizumab in 130 versus atezolizumab alone in the biomarker positives. You can see from this slide, this is 361, and this showed chemotherapy versus immune therapy alone versus immune therapy plus Pembra plus chemo, so identical. You'll remember the results of 130 showed hazard ratios of 0.82 and 0.83 for the chemotherapy combination to start with. It was a positive trial, but 0.83 PFS is not really enough to change practice, or 0.82, and 0.83 for OS wasn't statistically significant. So the ESMO Guidelines Committee met, and a number of other committees met, and actually decided that although it was a positive trial, we need OS to change practice. That was really helpful, because when the results of this trial came out, we saw actually quite similar results. From the chemotherapy perspective, the hazard ratio, again, for PFS was not statistically significant, with about a 20% reduction in the study arm. And here, the same problem with OS. And again, you can see the hazard ratio here not practice changing. So actually we can relatively confidently say at this point that the addition of chemotherapy to either PD or PD-L1 inhibitors, the two together, do not appear synergistic or actually even additive necessarily, perhaps mildly antagonistic, dare I say it. And under those circumstances, it's not delaying PFS, it's not extending OS. It's also important to remember that in these chemo combo trials, there was also the period of maintenance therapy after the chemotherapy combination period. Top right-hand curve, the chemo combo curve, the curves actually only go apart after the chemotherapy is finished. This is actually quite disappointing, and I was involved in many of these trials. Very disappointing, because we hoped we'd reproduce the lung cancer data with hazard ratios of 0.5 and 0.6. We didn't achieve that lofty goal. That's really important because it suggests to us that we need to find alternative approaches for the future. You'll know there's a randomized trial of EV, enfortumab vedotin, plus pembrolizumab versus chemotherapy alone, a really important study to see if actually we can beat chemotherapy in a different way. As things currently stand, instead of giving the drugs together, it appears if we sequence them, as is the case with the Javelin trial, where chemotherapy first for those individuals that don't have progression of disease, maintenance nivolumab, survival hazard ratio of 0.69, currently looks like the most compelling approach. This study also taught us a second thing. It taught us quite a lot about monotherapy, and it told us how confusing monotherapy was. Actually, when you look at durvalumab, atezolizumab, or pembrolizumab versus chemotherapy in the ITT population, not the biomarker-driven population, I'll come to that in a second. In the ITT population, the hazard ratio is 0.93 for pembrolizumab, 0.99 for durvalumab, and 1.02 for atezolizumab. Essentially, the drugs seem to be very similar against chemotherapy. You could throw a blanket over them, essentially. The challenge is, when we look in the biomarker positive population, we can see chemotherapy outperforming the immune therapy, and then the immune therapy trying to catch up. And that's what we can see from the bottom left-hand curve here. Actually, the 22C3 biomarker, the pembrolizumab biomarker, appeared to perform least well. The atezolizumab biomarker, actually, which measures IC expression with 142, shows a hazard ratio currently of 0.68. It's not statistically significant, but actually PD-L1 biomarkers are not the same thing. The 142 biomarker, the 263 biomarker, the 22C3 biomarker, and the 288 biomarkers for 4 individual drugs are performing completely differently. This trial gives us a huge amount of information that's incredibly important because it tells us the next direction we should go in. Number one, chemotherapy combination doesn't seem to be as effective as we would like. Number two, monotherapy doesn't get in control of enough patients to beat chemotherapy. And number three, the biomarkers are largely unpredictable. 361, a really important study, if we could move to the next slide. And the Danube trial, as I said before, really very, very similar. Chemotherapy, again, against monotherapy. Let's talk about the monotherapy first, because we have talked about that in some detail with pembrolizumab. And again, you can see with the monotherapy in the biomarker positive population, the top right-hand curve, chemotherapy outperforming immune therapy. Initially, immune therapy not catching up, resulting in a negative trial. Hugely disappointing, but consistent, and the consistency is relatively important. And then the other co-primary endpoint, durvalumab and tremelimumab, incredibly controversial, actually, not incredibly, quite controversial. So in the ITT population, in unselected patients, you can see no benefit. Again, the same problem in unselected populations, chemotherapy outperforming the immune combination. But it is important to note that that hazard ratio of 0.85 is numerically lower than the durvalumab hazard ratio of 0.99 in the ITT population. What this is suggesting to us, and we can see this from PFS and from response data, that the tremelimumab, the CTLA-4, is resulting in a 15% bounce in outcome. Tremelimumab probably looks as active as durvalumab as a single agent. This is quite important because it suggests we've got a new drug that works in our armory. And the bottom right-hand curve actually shows what would have happened had we selected a biomarker positive cohort, not the ITT cohort, for durvalumab plus tremelimumab, it would have been a positive trial. Now, I've had many studies where I've sat and said it would have been a positive trial, and this is another one of those. This is not a positive trial. It's not practice changing, but it is exploratory and compelling. It's compelling from response, it's compelling from PFS and from OS that tremelimumab is adding activity, particularly in the PD-L1 positive population. It's also doubling toxicity, actually. So increase in toxicity, doubling in steroid use, for example. But this is an important piece of our armory for the future. And there are trials looking at ipilimumab and nivolumab in a similar population, biomarker positive driven. And I hope that trial is positive. I wondered if that would be a good point just to take one or two issues. Sandy, what did you feel about what I've said so far? Maybe don't comment on the content so much, but perhaps on the data.
Well, it's a pleasure, Tom, to share these views with you today. I agree. I was a little disappointed that we didn't have a big change in our practice with either of these trials. And I too, like you, wondered about why this difference compared to lung cancer. You know, I mean, really thought that this chemo plus IO would change practice in bladder. And I wonder whether it's because bladder cancer is so much more chemosensitive compared to lung cancer. And it's just hard to beat chemotherapy, especially for those patients who are cisplatin eligible. We have such a good response. And maybe that's why the addition of immunotherapy here has been a bit of a challenge. And then clearly we have had issues with the biomarker. It's been so challenging and confusing about how specifically to pick this. And I too agree that the durvalumab plus tremelimumab really was an attractive design, and just seeing that in the PD-L1 high population that it's positive is promising. And I hope the ipi-nivo in PD-L1 high patients ends up being a positive one, and that'll change practice then.
David, I've got a question for you. Have you got a question for me?
Well, yeah, sure. Why don't I start with my question,
Okay.
since it's likely to be a better one. So actually looking at this data, and obviously not a bladder cancer person, I understand why a trial that fails to meet its primary endpoint is a disappointment, but in some ways this gives you a way forward, it feels like, meaning had you designed the trial differently, you would have a positive study. You know, if you remove the patients with cold tumors from your population, you know, the therapies that work in tumors that have an immune response at you know, the time of treatment, they do better. You know, to me, it feels like you learn something that's helpful here. You know, if the tumors have an immune response at baseline, well, they're going to respond to an immune therapy. These therapies probably don't turn cold tumors into hot tumors, but you see clear activity in that subset of patients. So why the long faces? Why isn't this like a way to move forward in the right patients?
Yeah, so David, with all those degrees behind you on the wall, I'm suggesting you're doing this from someone else's office. Is that correct?
They're actually not degrees, but I'm doing it from my office as opposed to you, where you look like you're in your art studio there. I'm actually coming to work these days, you know, like
so
some
David,
of us.
The answer to your question, which I think I'd like to actually push it back to you, if I may. When I first started, I had a lot of conversations 4 or 5 years ago with people saying you can't combine chemotherapy and immune therapy together. And it was because the effect of chemotherapy would be immune suppressive. And that's why there was no chemotherapy combination arm in Danube, because it was the first trial. It then became apparent, there was, I think it was a 228 study or something along that, it won't be that, some 22R, lung cancer study where it looked fantastic and then everything took off essentially. What do you know about the effect of chemotherapy on the immune repertoire? And because people always talk about it being more selective for Treg cells, which is resulting in the immune boost, but actually I'm not sure I'm totally bought into that concept. And it does seem like different chemotherapy agents have different effects on the immune system. Do you think that's a fair comment?
Yeah, I think it's probably true, but I think one of the other things we know indirectly from some of the studies we've done is that the immune cells that you are activating in many of these patients are immune cells that have already reached the tumor, found the tumor as a threat and are ready to kill it, and would kill it if it were not for the PD-L1 defense in the tumor or the microenvironment. So the chemo may have a negative effect on immune cells, but it's not necessarily going to have as negative effect on those immune cells that have already recognized the tumor as a threat. So I think that's partly why you see some combined benefit when you put those two together, at least in the short term. Now that said, ongoing responses are probably not enhanced by, chemotherapy or immune suppression in general. So, I mean, to me, the shorter the course of the chemo, the better. I think what we don't see with a lot of these combinations, chemotherapy plus checkpoint, targeted therapy plus checkpoint, is we don't see a lot of synergistic behavior. And what do I mean by that? Which is we see an increased response rate, but we see some increase in, say, complete responses for example, in kidney cancer, which we'll talk about. But that synergistic effect, that in the the concept of the targeted therapy or the chemotherapy killing cancer cells, which releases antigen, which is increasing antigen expression to the immune system, which is going to enhance the immune response, that theory doesn't seem to hold up as much as many had predicted or many had hoped. So I think in what you're seeing here in these trials, just like we're seeing in kidney cancer and in lung cancer, is mostly additive effect. You're treating two different histologies or two different biologic populations in these trials. Mostly the chemo sensitive, to Sandy's point, patients respond to the chemo, so that whatever part of that patient's tumor is chemosensitive is responding there. You're getting some immune effect, you're getting some overlap, but the actual synergy is, I think, rather disappointing with most of these chemo or targeted therapy combinations. That's my sense of this data, is you're treating two different biologies with combination, not necessarily. Go ahead.
Many people felt that the CTLA-4 combination would never be enough to get over the line to beat chemotherapy, and many people were skeptical about the CTLA-4 combination in urothelial cancer. Many people in the audience who follow urothelial cancer won't have ever used CTLA-4 in the disease. Could you just talk a bit about the melanoma experience and why the two drugs work well together?
Well, I think a couple of questions there. I think in general, CTLA-4 has significant single agent activity in melanoma. So it's not surprising that in combination you see dramatic impacts, not just increasing response rate, lengthening progression-free survival, overall survival, but you're seeing durable overall survival and the ability to create deep responses that allow you to stop the treatment. Now, in many of these other diseases, you don't see a tremendous amount of single agent activity with CTLA-4, but when you do see it, I think what it adds is durable benefit. It doesn't necessarily dramatically increase response rates when added to PD-1, but it improves the tail of the curve endpoints, which are not surprisingly the IO endpoints. It's not going to help you win in the targeted therapy or chemotherapy endpoints, which I see as response rate or median PFS. There, the targeted therapy or the chemotherapy is always going to outperform. But if you have the patients to wait to the tail of the curve, which most people don't, looking at things like landmark PFS and long-term overall survival, and combine that with a selection strategy that is not perfect, but at least eliminates some of the patients that were not likely to respond. You put those two together, you can have a positive trial, you can have an impactful combination. So like what I would want to know with this data set is, it seems like the durva-tremi curve is above the chemo curve towards the end, which is great. How many of those patients are off drug? Because that's an added benefit from a patient's perspective, is they're not just benefiting, but they're alive off therapy. And I think that's what you can get with the addition of CTLA-4.
The strange thing about this trial was actually that in the biomarker positive population, the response rate for durva-tremi was exactly the same. It was about 1% lower than chemotherapy. So there was actually I think CTLA-4 is actually very active in bladder cancer, and it's been overlooked. I'm going to keep going with my slides, if I may. I've only done two and I'm over halfway. Trophy. So I'm going to talk about antibody drug conjugates quickly. This actually is not the biggest news that happened during the ESMO period. The biggest news that happened during the ESMO period for antibody drug conjugates is that enfortumab vedotin, which is a nectin targeting antibody drug conjugate, which has activity in urothelial cancer, nectin widely overexpressed, showed a survival advantage compared to standard chemotherapy in tumours that had progressed after both standard platinum-based chemotherapy and immune checkpoint inhibition. This is a practice-changing result. Actually, the hazard ratios were given in the press release. I'm not going to talk about them today, but you can find them if you want them. I'll wait till the presentation comes out. But essentially, it is, in my opinion, practice-changing. And the reason why that's the case is the current treatment paradigm, as I described so far, will be based around frontline chemotherapy for the foreseeable future, followed by maintenance of avelumab. And then at progression, which is second-line therapy, enfortumab vedotin will become the standard of care, in my opinion. The drug has toxicity, as most antibody drug conjugates do. That includes neurotoxicity, hypoglycemia, fatigue, skin rash. But essentially, it's an important step in the right direction, because now we've got targeted therapy with FGF inhibition, antibody drug conjugates, immune therapy, I hope immune combinations, and biomarker-driven therapy in urothelial cancer. This has all happened in a period of 2 or 3 years, actually. So while I've shown negative results, what I could actually turn around and say is, compared to 10 years ago, bladder cancer is completely different. Trophy 1 is sacituzumab, which is, I'm going to call SASA, which is some call it SG, which is also an antibody drug conjugate. As you can see here, this is very similar setting to the enfortumab vedotin environment, with individuals who have previously had immune therapy and chemotherapy. You can see the response rate here, the progression-free survival, and the overall survival looking promising. Now, I know people want to overinterpret these data, and I know the response rate for EV was 40%. These are a little bit lower than that. And I think that making these cross-trial comparisons is unwise, but it was announced at the meeting that there would be a randomized phase 3 of SG versus chemotherapy, an exact repeat of the enfortumab vedotin trial that's just been broadcast. Clearly, a potential shortcoming of that trial design is it's 3 years after the EV study, and how many patients the control arm will get access to subsequent EV. This is a really exciting area for the future. I've got one last slide. And this is the Javelin Bladder 100 program had a huge amount of data presented. The data included looking at response and whether frontline chemotherapy response influenced outcome with immune therapy. And essentially, avelumab appeared to work irrespective of the type of chemotherapy, gem-cis or gem-carbo, and the type of response to therapy, whether it was a complete response, partial response, or stable disease. The bottom right-hand curve shows a quality of life curve, which shows no detrimental effect on quality of life associated with avelumab. We need to study this in detail, but it's reassuring from a patient perspective. Clearly, it's a 2-week infusion, which is an important time commitment, but it's not having a significant detrimental effect on quality of life. And the bottom left-hand curve, I would encourage you to go onto the ESMO website. Carla gave a terrific presentation. Petros also gave a presentation from these data on the biomarker program. And that biomarker program is very robust with protein, RNA, and DNA analysis. The slide I picked out here highlights the role potential of TMB, not in isolation, but perhaps with other biomarkers in the future. The next slide is my final slide. And I think that the final slide comes back to that where we started with the atezolizumab issue, atezolizumab plus chemotherapy. We saw some quality of life data being presented, and we didn't see that the addition of immune therapy added significantly to toxicity, and it didn't seem to have a huge effect on quality of life. Some people have come to me and said, is that because there's no synergistic effect and it's not working as well? I'm not sure that's the case, But it does appear that we can at least combine these drugs safely. Whether or not their practice changing, we'll have to wait and see, because it's possible that IMvigor130 does result in a survival advantage. It's important to remember this trial is not finished. Unlike Danube and 361, 130 has only had interim analyses, and this trial is ongoing. I'm sure my next slide is my last. And I think we've talked about this in detail. I think we've talked about the role of IO in the first line setting, the biomarker being unpredictable, and the future being around ADCs and FGF with immune therapies.
I have a question for you, Tom.
Yeah, Sandy.
I'm curious because I think for the Javelin, I get asked this quite a bit, and I would love your take on this, where we don't look too much into the subgroup analysis, but clearly it seems like the complete responders hazard ratio was a lot different than the partial and stable disease. And in a place where you have access to immunotherapy and where surveillance is definitely part of the big picture, how compelling is it to do maintenance in a CR patient?
Yeah, so I think the CR numbers were relatively modest. So the numbers are small because not that many patients get CR in bladder cancer. So that's important, number one. Number two is that the number of events were relatively small because we know those patients do well. So I would say it's too early to tell as it currently stands in that subpopulation. In the ITT population, we know that there was benefit, and really importantly, in the good risk population, in the CR population, the PFS was very different from one another. And so what I would say is the PFS is currently compelling, the ITT study is positive, the OS is currently immature. There's a good chance those survival curves do look like they're going apart. Now, they haven't gone significantly apart yet, but you can't really get significance in these forest plot analysis. So I would say it's too early to tell how big the survival advantage will be in the CR population. But as with 214 and other studies in the past, the subset analysis piece, I think, can potentially be overinterpreted. And I think that's potentially what's happening here. I would treat this group of patients because it's quite difficult to have that conversation with the patients and we'll wait for the cancer to come back and then we'll give you the immune therapy then. We've got a randomized trial which shows that there's a 30% reduction if you give it early, but we're not going to do it to you. And there's a subset analysis where the PFS shows a benefit. We haven't hit the OS yet. You know, I don't recognize that conversation. I think if in the long term, a more mature analysis shows absolutely no difference or, heaven forbid, detrimental effects, that would be different. And then I think the other issue is it is quite a small subset of the patients. And that's important to remember. And we need to be very careful when doing subset analysis on only 10% of patients in a forest plot. I've gone over by about a minute or 3 minutes.
Sandy, it's okay, Dr. Powell. Not a problem. The discussion's been great. And up next, Dr. McDermott will walk us through RCC. And we hope to continue the great discussion that we're having.
Thank you, John. Could I have my next slide? So 5 years ago in kidney cancer, the standard of care for most patients was VEGF therapy first, followed by PD-1 blockade second. Over the last several years, we've seen major improvements in outcomes for our kidney cancer patients, several very positive randomized trials that have essentially improved outcomes by bringing PD-1 blockade into the front line. Most of those combinations, most of those trials have involved the old front line, which is VEGF, and the old second line, which is PD-1 or nivolumab. Some have been, as we've talked about before in the bladder section, PD-1 and CTLA-4. Here's another entry in the PD-1 plus VEGF combination bucket. This is nivolumab and cabozantinib, so-called Checkmate 9ER study, which was presented for the first time at ESMO. Similar study designs to the other VEGF combination trials where the combo was compared to the old standard of care of sunitinib. And the results were very similar to what we've seen with PD-1 and VEGF. The trial that Tom led with Brian Rini, the Keynote 426, which is the other entry here of exitinib and pembrolizumab, showing very similar results. The combinations with PD-L1 blockade also meeting their primary endpoints, but less, less clear results, let's just say that. But in the 9ER study, Clear benefits for those patients getting the combination. You see the survival curves here, the hazard ratio for survival, 0.6, favoring the combination. The curves separate early and remain separate. Similarly, in progression-free survival, a clear benefit, a 50% improvement in median in PFS on those curves, favoring the combo. And in the lower left, you see the objective response and best overall response. You see, much higher response rates with the combination of 55% in a similar range to what you see with exitinib and pembrolizumab, clearly better than sunitinib. Also a higher complete response rate and more deeper responses in the combo. And why this is important, I sort of alluded to this before. We know with IO-based regimens, the deeper the response, the more likely it is to be durable, the more likely it is to translate into overall survival at 5 years. And for some of those patients, you can actually stop the therapy and they can live in treatment-free survival. So this is a clear practice-changing result, and almost certainly will lead to the approval of this combination and be added to our armamentarium for untreated patients. Another reason this trial is important is because it sort of brings Nivo and Cabo not only to the front line, but it gives us a sense of what might be coming down the road, where we combine all three approaches that have been used in frontline kidney cancer, combining Nivo, Cabo, and ipilimumab in the so-called Cosmic 313 trial, looking at VEGF, PD-1, and CTLA-4 in sort of a kitchen sink approach compared to ipi-Nivo. So that'll be the next important trial we look at as far as changing practice in the front line, but we'll have to wait a year or two for that result.
David, do you think if you could choose ipi-Nivo, let's just start with a simple question. Axi-Pembro and Cabo-Nivo, does one look better than the other to you?
Well, I think the major difference, if you compare the trials, is, in my opinion, is how the sunitinib performed in those trials. In your trial, KEYNOTE-426, both arms performed well. Here you look at the PFS for sunitinib of just 8 months, which is less than we saw in KEYNOTE-426. And I think that explains the hazard ratio that you see there. So I think the results for the combinations are pretty comparable. I think the CR rates are similar, response rates are similar. I think in some ways, I was hoping maybe that with the dirtier drug, cabozantinib, you might see a higher CR rate. Maybe we'll see that in the future. I mean, there's some people who believe blocking MET and AXL can enhance the immune response to the tumor. That's not showing up yet in the early data. Maybe we'll see it later. I do think practically, though, my personal experience with Cabo, it's obviously a very potent drug, but it has a longer half-life. So when I'm using in combination, I find it a little easier to manage patients on Axi-Pembro. So for example, if a patient gets diarrhea and you're not sure whether it's the Axi or the Pembro, if you stop the Axi, well, they get better in a day or so. With the Cabo, you usually have to wait a little longer to see if the Cabo is driving the toxicity because of the longer half-life. I find that a little bit more challenging, but the safety data from this trial is also very encouraging. So people should be encouraged to use either combo and see what is most appealing to them. What are your thoughts on that subject?
So I think similarities and differences. I mean, I liken it to two identical twins, and most people can't tell the difference between the two. Maybe the parents can. I'm not sure who the parents are in this particular scenario, and I'm not sure how well this analogy is working.
It's falling apart quickly, I think.
But one could say, that it's very, very difficult to find differences between the two. Yes, you can find them if you look very hard, but essentially they look very similar. Right,
agreed. Sandy, any thoughts on that question?
No, I agree. I think, as I think about which therapy to give, again, cabozantinib has always stood out as a great option for patients with bone mets. And I think this trial continued to demonstrate that. So we may start picking and choosing who you would do which one for. I like Cabo-Nivo for that real aggressive, highly symptomatic patient, especially with bone mets where you want a response faster than you would with, let's say, ipi-Nivo.
Okay. All right, let's go to the next slide. Thanks, Sandy. So here's a trial, another frontline study with another combination. This is looking at PD-L1 blockade with atezolizumab and VEGF blockade with cabozantinib. This is a trial that looked at 2 different doses of cabo with the standard dose of atezo. And this study is interesting for, I think, for a couple of reasons. One, it showed interesting clinical activity. You see here the tumor response by investigator. You see, response rates north of 50% regardless of the dose of cabo. You do see some, an encouraging CR result with the higher dose of cabo, so that bears further watching. As I mentioned before, I think those are the kind of responses that get me interested in a combination. Next slide. If you look at progression-free survival as seen here, this sort of wasn't intuitive when I saw this. You see a median progression-free survival that's actually longer with the lower dose of cabo. Now, this may have something to do with tolerability over time. The 40 milligram dose, in my experience, is easier to tolerate than 60, and probably maybe fewer dose reductions. I'm not really sure what to, it seems like the PFS and response rate data are somewhat different here. But also encouraging, which is good. And another interesting thing about this trial is the look at some different potential predictors of response, PD-L1 status and CD8 T cell status, so that signs of infiltration of the tumor, immune response of the tumor, defense with PD-L1, all maybe not surprisingly associated with higher response rates, sort of giving a further sense that you can enrich for response, although there's still plenty of responses in the negative group with both potential analyses. So not by any means not a perfect marker, and when you combine them, you got some improvement in prediction ability, but not a lot. So we still need a lot more work there. I think the reason, though, this trial is important is it shows these 2 are safe and you can give them together. And these 2 are being explored in the second-line setting where cabo is also a standard. So that is the CONTACT-3 trial, which is cabo versus cabo-atezo. It'll give us the first trial that I'm aware of that'll give us some prospective data on what to do when patients fail PD-1-based combination therapy. We don't have a lot of prospective data there. So it's good to know that this combo will be explored in that setting. Next and last slide. So this agent here, this target here, this is a very interesting story. I could talk about this for an hour, but I'll try to do it in just a couple of minutes. This is interesting on several levels. So the biology here is important. Many clear cell kidney cancers are have a VHL mutation. When VHL is lost, levels of hypoxia-inducible factor rise within the tumor. This is a transcription factor that we think drives many clear cell kidney cancers. And traditionally, transcription factors have been very hard to drug. But now we have this drug here, MK-6482, that actually prevents HIF-2 alpha from working by, as you can see here in these pictures, by inhibiting the binding of the alpha and beta subunits of the molecule, so it can't do what it's supposed to do. It can't drive the production of a variety of different proteins that drive tumor growth. So when you hit a clear cell kidney cancer with this targeted therapy, you're actually targeting the tumor, which I think is important, with a pretty non-toxic, or I shouldn't say non, because it's not non-toxic, but a pretty tolerable drug, and you're seeing encouraging responses. This is looking at patients with VHL kidney tumors, and over a third of them having a response. Dr. Choueiri presented data on patients with metastatic kidney cancer and showed a 25% response rate with this targeted therapy. So this is proof of principle that HIF-2 alpha is important, that it can be drugged, that these responses can happen, that it can be tolerable. So this agent is now in phase 3 trials in kidney cancer and will almost certainly move up in combination with other agents. It's probably one of the more exciting developments in the kidney cancer field in several years. So we're looking forward to more data on that. And then my last slide was just some of the discussion points we had. And I think we've talked a bunch about this, but why don't we just go with Sandy, your thoughts on how do you choose between IO, and IO TKI for your patients? I think that's probably the most topical question on this list.
Well, I definitely think that complete response, patients coming off all therapy, having an opportunity where they can actually have a CR and be cured, to me seems like the #1 goal that I want for patients. So I definitely start with Ipi/Nivo as my first choice. But obviously there are patients now that you have so many other options. I then think about, is there a patient who's not an EP candidate? Like everyone else, there's some fear about EP and its side effects compared to all of the other immune therapy. So if I feel that somebody is a little frail, I might go with the IO VEGF combination. And now again, we have so many that I think you need to have a list of TKIs and you have a list of your IOs, and it's almost like you pick and choose which one from either of that list and it would be okay.
David, my perspective is that the pendulum has swung towards VEGF TKI and immune therapy with the Cabo-Nivo data. I think that the immune VEGF combinations are better at getting initial control of disease. There are some patients who need early VEGF TKI. If you give Ipi/Nivo, you will lose those patients. I think Ipi/Nivo may be better at getting long-term control. We don't know that yet because we haven't got the mature data for Axi/Pembro or Cabo-Nivo. I think from a cure perspective, I don't think any of these drugs are curing enough patients. CR rates of 8% versus 10% is not a coherent argument from my perspective. If it was 25% versus 8%, I'd be brought into that. But at the moment, there's no evidence that Ipi/Nivo is curing more than Axi/Pembro or Cabo-Nivo. I'm impressed by the durable PFS of Ipi/Nivo. I'm impressed by the quality of life data, but I don't think there's evidence at the moment it's curing more patients.
But one thing that I haven't seen with either of the two trials, Tom, is what fraction of patients are able to come off treatment. I mean, it just seems like you'll end up being on a drug, whether it's the IO or the TKI, and I'm hoping we'll be able to see that data sometime.
Yeah, I mean, the discontinuation issue, David, I know you know a great deal about this. The problem with discontinuation with Ipi/Nivo, of course, is the issue is the only patients who discontinue the drug get into problems because they've discontinued because of toxicity in the trial. So it's the equivalent of, you have to crash the car before you get out of it.
That is not right.
We're not.
You're being silly now. Go ahead.
No, just to take the argument to the extreme, and I realize I am doing that, David, and it is your turn next. But it is an important concept that the principle of discontinuation of Ipi/Nivo can be done safely in all patients is not yet proven. And I think that the arguments around whether or not one can discontinue these drugs, again, I would put it to you that that's not yet been proven for Ipi/Nivo. And in the trials, treatment-free survival was based around those patients who stopped, and most patients who did stop because of toxicity.
All right. Well, I obviously agree with Sandy, but we don't have time for me to school you on this. I think time will tell. And as she points out, the bar is high. You have to beat 35% long-term progression-free survival. That's the bar that you see with Ipi/Nivo. That curve is flat. Let's see if your curve is flat 2 years from now. My guess is it'll be like the rest of you, not flat. It'll be drooping. It'll be severely drooping.
I'm happy to have a debate, David. As you know, I love a debate. Sandy, I love a debate.
Yeah, okay, good.
I also think, I mean, if you're not getting patients off therapy, then I think you have to sort of think about the patient in their entire spectrum of their life expectancy. And it becomes now, I mean, first line has become so complicated that we can't even think about what the subsequent therapy is going to be.
I agree with that. And I'm going to, David, I know I'm taking up all your time and starting to be yours too. I really apologize. So the goal of renal cancer currently, 5 years ago, everyone was dying. Our goal is not getting patients off therapy currently. The drugs aren't that good. The CR rate's only 10%. The goal has got to be long-term durable remissions. I saw 20 patients in clinic yesterday. I didn't have a conversation with any of them about stopping therapy. Most of them are just saying, how on earth can we get in control of disease? And that seems to be the primary goal. I agree, in the years down the line, maybe triplet therapy, quadruplet therapy will be able to achieve that. But actually stopping therapy and being in long-term remission off treatment is the minority of patients as it currently stands. And we need to focus on the majority about getting early control of disease.
Okay, well, you could be right. I think you're probably wrong. The melanoma experience suggests that you're wrong. We'll have to wait to prove it to you. Okay, let's just wait. We'll wait.
David.
I didn't say I proved it, but it can be proven, and you need to keep your mind open to the fact that remission is possible. We're probably over-treating some patients.
My mind is open, David.
Patients want to be alive and off drug, not just alive.
But they want to be alive.
I'm alive is good. Right now, we're doing good on alive. We're going to do better.
5 years in kidney cancer, we weren't that good.
I understand. Well, thanks to your hard work, things are looking up. All right, Sandy needs to go before we run out of time.
Sandy, I'm really sorry to take up so much of your time. I apologize.
No, I think we are perfect. So for prostate, fortunately, just starting off, things have changed so much. I think 5 years back, prostate would have been first on the panel with about 7 abstracts, and bladder would have been at the bottom with 2. So clearly the pendulum has changed, and it's awesome for our patients. So for ESMO, prostate was not super practice changing. So I thought I would focus on these 3 abstracts: the profound, ipatential 150, and we'll talk about a new drug. Next slide. So coming into ESMO, both, there were 2 PARP inhibitors that were FDA approved: olaparib in patients post NHA, and rucaparib for patients with BRCA1 and BRCA2 in patients who had had 1 prior NHA and docetaxel. So PARP inhibitors have been really a novel agent for us with the additional drugs that we have had in prostate cancer. This trial, PROFOUND trial, was the phase 3 trial looking at patients with metastatic CRPC who had progressed on 1 prior NHA. And they were put in 2 different cohorts. Cohort A included patients with BRCA1, BRCA2, and ATM. And cohort B included all of the other 12 different HRR genes. And in each of these cohorts, they were randomized to either olaparib or to the alternate NHA. This has been a little controversial about the choice of the control arm, but at the time that these studies were designed, chemotherapy use was not very common, and most physicians in practices were sort of sequencing 1 NHA after the other. But nonetheless, this trial received its FDA approval based on having an improvement in radiographic progression-free survival in cohort A. And at ESMO, we saw the first time the overall survival, which was the secondary endpoint. You can see up in cohort A, for the patients with BRCA1, BRCA2, or ATM, there was an improvement in overall survival. And I think more important was that about 2/3 of these patients had a crossover. And even with adjustment for crossover, you can see that there was an improvement in overall survival. On the top-hand corner panel, you can see that the overall survival for the all comers the curves were trending towards an improvement, but there wasn't a statistical significance for the entire cohort. And definitely for patients in cohort B, there was not a statistical improvement in overall survival. So we have PARP inhibitors. They've become part of our standard of care. The question now would be, would there be any, based on this data, any comfort in treating patients besides BRCA1 and BRCA2 with PARP inhibitors? We don't have that great response as we see with cohort A. Tom, I know that in UK and in Europe, there was some decisions made. In the US, olaparib has an approval for all comers. There's some restriction in the UK about the use just in BRCA1 and BRCA2. Is that right?
Yeah, I mean, it's so confusing, isn't it? And I don't know the answer to some of the questions around the the biomarkers for PARP. I think DDR signatures, and I've worked on them quite a lot in urothelial cancer in different forums. And, you know, they're a bit unpredictable. And certainly we did some work looking at beyond BRCA1 and BRCA2. It does appear to me that BRCA1 and BRCA2 are the strongest drivers. And in prostate cancer, some of the data on some of the other markers like ATM is not that fantastic. And obviously there are a plethora of other potential biomarkers that we can throw in. One of my concerns around this is we haven't really nailed the biomarker issue. There's a somatic versus a germline biomarker, and obviously there's that long discussion in ovarian cancer. We're going down a different route with these particular drugs in prostate cancer. I'm actually quite confused about the BRCA biomarker or the DDR biomarker in prostate cancer for PARP inhibition. And I don't necessarily disagree with what the UK has decided.
Yeah, I mean, I think the big issue around this, for me, a big take on this was that we need to be doing testing. If you don't do any tests, you're not going to have access to these drugs. There's a lot of discussion around what is the optimum timing to test in prostate cancer. It's certainly a challenge because we have many patients who have had a prostatectomy 20 years ago, and what's the accessible tissue? Fortunately, there is a germline testing, I think, especially for patients with newly diagnosed prostate cancer, that may be the optimum time to do a germline testing. And for patients who have any tissue available, I think testing for these somatic mutations is going to be really relevant, because maximum benefit is from BRCA1 and BRCA2, especially if you look at the hazard ratio for these mutations.
I agree, and the principle of synthetic lethality, which is where this started, is based around the loss of the second copy, which, you know, clearly you need to be halfway there before you start. And so I think the unrestricted label for me doesn't, I've got to say, it doesn't make as much sense as perhaps I'm somewhat supportive of the biomarker-driven approach that the UK has taken. And I'm not just saying that because I'm from the UK. I disagree with almost everything else we're doing at the moment.
Well, you know, like in a lot of other diseases, we have taken a drug, and if it's effective, it gets moved on to earlier and earlier lines of therapy.
Yeah.
I think here we have the hormonal drugs, which in general are really well tolerated. And then we have PARP in between, and then sort of chemotherapy is pushed a little bit to the end. Do you see, based on, I mean, one of the concerns that have been raised with PARPs is the myelodysplasia and possible leukemic potential. Do you see any concern in moving PARPs even to an earlier setting?
So in prostate cancer, I think it's one of those issues which inevitably will take place. The driver will be around efficacy and the biomarker selection. And I think you've got another study coming up in a second, which looks at perhaps looking in a slightly earlier place with some biomarker selection. And there you're delaying disease-free survival, but not moving the overall survival curve. So what I would say at the moment is I would prefer, if it was me, I'd prefer to learn more about the biomarker and more about patient selection before doing very big practice-changing frontline trials, which where we haven't quite understood the biology as much as I think we need to in prostate cancer. That's my personal opinion. I'm sure other people disagree with me.
David, I have a quick question for you, that in kidney, we have so many different platforms. Are they all similar? I mean, here in prostate, we end up using Foundation One. We have the Guardant that's used for liquid biopsies. What's your take on all of these testing, and what advice can we offer our practitioners?
Right. Well, I'm not aware of head-to-head comparisons of the platform. I think the blood-based platforms obviously have significant advantages from a practical standpoint. They may also have some technical advantages as well. That remains to be seen. But from a point of care, a point not just determining whether patients should get a certain therapy, but following them while they're on therapy, I think they offer advantages. You know, we're exploring some methylome type work in kidney cancer, which may actually be more useful than, you know, tissue-based stuff. So I think it's worth exploring, but eventually to answer your question, you would need head-to-head comparisons. I just don't see those happening of the different technologies. Personally, I don't know what Tom thinks, but I don't see that happening.
I think my impression is the same as yours. Is I get a feeling that as soon as we have an excuse to move away from tumor-based biomarkers, with all the challenges of the historical data, fishing them out of the lab, not always getting access to them, I think we're going to move on to circulating biomarkers very quickly. That's my opinion.
Okay, great. Thank you. Can we move to the next slide, please? So this is a trial, it's not practice changing, but I think it was a really important trial looking at an AKT inhibitor, which in a phase 2 study had pretty impressive results, especially in patients with PTEN loss. So this was a large trial that took patients with metastatic CRPC and randomized them to either ipatasertib plus Abi versus a placebo with Abi. And the co-primary endpoint of this trial was rPFS in the whole population, and also looking at the population with PTEN loss. But here the PTEN loss was done by IHC. So you can see up here that the primary endpoint in the intent to treat was negative. There was not a statistical significant difference between the two populations. But if you look at the PTEN loss by IHC, you can begin to see that there's some separation of the curves. But I think the most important take for me from this study was the difference that you can see. There was a small number of patients, about 200 patients, where they did PTEN loss testing by next generation sequencing rather than IHC. And if you look at that bottom curve, clearly the separation is much, much bigger. So had this trial been designed to just look at radiographic progression-free survival in a genomically driven PTEN loss patient, I think we would have had a positive trial. So I think there is some signal here, and I hope that this drug continues to have some traction in this field so that we can get this drug available. Quick question to either of the panelists. What do you think about the difference in this IHC versus NGS testing?
I think that this whole biomarker program was quite complicated. I think that the biology is exciting. Clearly, there is a relationship between PTEN and PI3 kinase, as has been demonstrated, or AKT has been demonstrated here. I think that the original phase 2 design used a slightly different biomarker, and a more easily applicable biomarker was chosen for the randomized phase 3, and now a completely separate biomarker has been identified as a potentially more exciting. I always worry, going back to my bladder cancer experience, when we shift from exploratory biomarker to exploratory biomarker, keep getting promising results, but never absolutely nail it. Having said that, this is currently a positive study for PFS, and that needs to be acknowledged. And we just need to see where we go from here. You know, I just feel that switching biomarkers from the phase 2 to phase 3 that may have been important in this, because that's a dangerous thing to do in drug development.
Yep. So in the last few minutes, I want to go on to the last trial. Next slide, please. Again, this is a first in class. I think I found it really exciting because bringing in immunotherapy to prostate cancer is really something that we want. And I thought that BiTE therapies are now used commonly in other cancers like myeloma. So I found this PSMA targeting BiTE therapy was a pretty promising abstract. Again, these BiTE agents, they target both the T cells with CD3 and they target the tumor cell. So having a PSMA as an ability to target the tumor cell, I think just opens this field for a variety of additional therapies. So this is using AMG 160. There were 2 parts to it. And at ESMO, the first part with monotherapy was presented, and there's plan to combine this with pembrolizumab. But if you look at the small cohort of patients, the PSA greater than 50, you can see happened in about a third of patients. And like all other BiTE therapies, the cytokine release happened in a large number of patients. But I think with all of the experience that's been gained from myeloma, there's a lot of comfort in taking care of this cytokine release syndrome. So I think I'm going to stop with that just because we are running out of time, but really excited that drugs like this would become more common in prostate cancer. I think we covered most of our discussion topics, and I'm going to hand it over to our moderator.
Great. Thank you so much, Dr. Srivastava, and many thanks as well to you, Dr. Powles and Dr. McDermott. This has been a great session talking about some of the updates in GU tumors at ESMO. For those who attended, the session will be posted as well on our YouTube